Dr. David Shires is a general practitioner whose interest in the role of families as caregivers in mental illness stems from his own family's experience with schizophrenia. He believes that nothing short of a social revolution will change the perception of mental illness in our time.
I want to try and talk a little bit about early intervention in psychosis. It's a thing I've been particularly involved with in England. And to use that as an example of how one works collaboratively, particularly with the emphasis on family practice. And I think really importantly that the evidence base that Gráinne has just talked about, what I've seen in the services that have developed in England is an actual application of that model. It's a really core component of how early intervention in psychosis services have and are making differences to people's lives. In terms of background, I'm come as a jobbing GP from the Midlands, from a place called Stoke-on-Trent, where we used to make pots a long time ago, so we were known as the Potteries. My wife Anne was a district nurse. We've got 3 children. Mary's the eldest, and the time I'm talking about is about 17 or 18 years ago, when Mary was 16, and that's when she first became unwell. And as jobbing health practitioners for Anne and myself, it was a real shock, the sense of who we are, and having a control, feeling as though you have a control over your lives, to suddenly be faced with a situation where we no longer had control was quite shocking, and there's the sense of complete loss of power and autonomy. I can still touch that sense. So Mary was at that point at age 16, and she had a very difficult time, a difficult adolescence, seemed to be being bullied at school. And for about 12 months, we sought help from the Child and Adolescent Service. They were confident that Mary had a thing called schizophrenia. And for 12 months, they tried their best. We had 2 weekly outpatient clinic appointments and conversations mainly about medicines, and very little support otherwise. And not poor staff, but staff that just didn't have the resources to give us support. The advice from the child and adolescent psychiatrists was if we could just hang on to the adult service, they were more into psychosis. And this was not a poor clinician. Eventually, we had a crisis situation, and Mary went into the acute adult service at the age of just 17. And I suppose the overwhelming feeling was that we'd gone from a service that maybe didn't do psychosis, but we'd gone to a service that didn't understand the needs of young people, nor families really. So that was a shock. After about 6 months in an acute adult ward where there really was nowhere else to go, Mary just became iller and iller. We felt we'd let her down. She went into a rehabilitation service. Now that was an 8-bedded dormitory with no curtains or carpets, and this was called rehabilitation. It's an old Victorian asylum. So we began to get a bit suspicious about the names of things. One of the things that happened there, which was remarkable, was that a new psychiatrist became Mary's psychiatrist, a lady called Fiona Macmillan. And Fiona's a very rebellious psychiatrist, and Gráinne knows her well. And she actually encouraged me to complain. And it was interesting. I mean, that was a great example of collaboration, and quite a brave thing to do, I think, as clinicians. But Fiona recognised that actually for her to influence service change was quite tough. But to work as an alliance with a family member was actually an effective way of doing it. I wanted to know if Mary was unique, and so we organised a Pathways to Care audit in North Staffordshire, where we lived. And it took about a year, and we recruited people to help, and it was a very positive thing. We wanted to change how services worked in North Staffordshire. And what did we find? Well, we found that primary care was involved. That actually these pathways, 70 or 80% of the time, primary care were key players. That people tended to get very late intervention. They tended to get crisis. So 80% of these young people were hospitalised. They were young. That was the other thing that really struck me. I hadn't understood it as a GP. But the age of onset of conditions like Mary had, Mary wasn't that unique. Mary certainly was not unique. So these were young people. The other thing that shocked me was Diane, the CPN, who went to talk to the families about the pathways. They'd say to her, well, you're the very first person that's asked us anything. Now, these are people who had sometimes relatives in hospital for several months. Diane had been the first person professional to say to them, how was it for you? And they also said, when are you coming back? And I think that's an indictment. That told me something about how services were working at the time. So we set up a quiet little rebellion in the Midlands. And Fiona had actually helped to develop the very first early intervention service in Birmingham with Max Birchwood in 1992. And I think in talking to colleagues from Dalhousie, that you were setting up a service of a similar type in about 1995. So there was an emergence of services in different parts of the world. And we've made good friends with people in different parts of the world as these developments have come on. So in the UK, the first service comes in 1992. And it wasn't that complex. First of all, we thought, well, it's important to use an evidence-based approach, which is what Gronya's been talking about. So we felt it was very important to have a balanced approach, which included family work, included cognitive therapists for individuals, and included sensible use of medicines. So I have no particular axe to grind about medicines, but it's how they actually blend with other things. So an evidence-based approach. We thought it was very important to shake some of the age constraints. It seems daft to have such a sharp cut-off at 18. As a family member, it just made no sense. So we've tried to base the service development on the notion of 14 to 35. It was a put-up or shut-up moment for me, and I actually stopped my job as a GP. I got very over-involved, and I got offered an opportunity to co-lead a national development programme on early intervention in England. And many said that the family support had actually increased and that they'd felt closer to their families. Now, that isn't always the experience that families and consumers have. So here's a service development that's actually, I think, causing a paradigm shift. And remember, I'll never forget going to see Martin in his office to hear about the results of this year of work. And he said, well, David, it looks as though we're saving about £5,000 in the first year and £14,000 by year 3. And I thought, well, it's all right. And he said, no, that's per person. Right, that's per person. So there's 7,500 young people have a psychotic illness each year in England, and we're looking at a 3-year package of care, 22,000. So I think 22,000 multiplied by £14,000 is quite a lot. And probably quite a lot in Canadian dollars too. I was trying to think, how do I just describe what it's like, really? This for Mary, this is Mary's care team. Okay, this is 3 years ago to a family wedding, one of her brother's wedding, and I suppose the important thing here is that Mary was written off. And we were written off as a family, and the pathway that Mary actually has is really one full of impairments and disabilities. And this is the care team through thick and thin. And it would not make good sense not to engage this lot in how you think about people like Mary, particularly at the start of the journey, but bearing in mind that this is something that goes on. And of course this care team is changing. Little Benjamin wasn't even thought of then, but Mary has a new nephew. Yeah, we got it right. Yeah, new nephew. Benjamin, aged 2. So you can see how, Anne and I won't be around forever. So the ability of this unit to support Mary is really critical. So we are very important. We are, in a sense, an accountability to the system. And if we talk about collaborative care, we need to think about components like the social care inputs. So I just wanted, this team are still very active. It's not been an easy ride, and we still think we're very important to how Mary copes. Okay, so I think I'll hand back to Gronya at this stage.